Welcome to the Pulse of St. Louis. I'm Shirley Washington. Tonight, we take a closer look at a new federal guidelines regarding prostate cancer screenings. You may recall 5 years ago, the government's U.S. Preventative Services Task Force was opposed to men getting a PSA screening. At the time, a local doctor took exception to the panel's decision and launched an aggressive effort to encourage men to get screened. Take a look.
Cancer is a scary word.
Lake St. Louis Police Chief Michael Force had a PSA test nearly 2 years ago, which indicated he had prostate cancer.
It is by far one of the more curable cancers if caught early.
Force, a former Marine, appears to have beaten the potentially fatal disease thanks to early detection and a form of radiation therapy.
But I'm doing great. There were a few side effects from it, minor inconveniences.
The PSA test, which measures how much prostate-specific antigens are in the blood, is shrouded in controversy.
One of the studies was a Swedish study.
After 2 studies were published, the United States Preventative Services Task Force announced it recommends against the PSA test for prostate cancer.
One problem is that they looked at those trials too early. The other problem was that one of the trials was contaminated. The people who were supposed to be unscreened actually wound up getting screened.
Dr. John Bedwinek, a radiation oncologist with a specialization in prostate cancer, strongly disagrees with the federal guideline.
The government was wrong in advising against screening. What's more important, and what they didn't look at, is prostate screening decreases the risk of your getting bone metastasis.
Bedwinek believes men between the ages of 50 and 70 should be given a PSA test and advises them to roll up their sleeves and give a blood sample to be analyzed.
What we're looking for are those aggressive cancers that are going to go to the bone. That only makes up 30 to 40% of all prostate cancer, but those are the ones that we want to find.
Force, a father, grandfather, and fierce advocate for the PSA test, says it made a huge difference in his life.
Or had I not listened to physicians or been the way many men typically are, stubborn, I might not be sitting here today.
Well, now the U.S. Preventative Services Task Force has changed its mind about the PSA screenings. And joining me now, Dr. John Bedwinek, a radiation oncologist at SSM Health St. Clair Hospital, and Jeff Bozier, a prostate cancer patient, and Carol Bozier, Jeff's wife. Thank you all so much for being here. Dr. Bedwinek, let's start right away by talking about the panel's decision. What exactly did it decide now?
Well, they initially gave prostate cancer screening a D, which means that the benefits are outweighed by the potential harms. And they raised that grade to a C. And they backpedaled, and what they have said is rather than recommending against screening, they're now recommending that patients discuss PSA screening with their physicians. So even though they've backpedaled a little, not really very much.
Because they still did come out and say men should get the screening.
They did.
They're saying that men should talk with their physicians about getting the screenings, correct?
That is what they said.
So how does the current decision align with what the American Cancer Society says and what the Urological Association says?
And that's pretty much, it's very similar to the American Urologic Association. They say that men between the ages of 55 and 70 should have a discussion with their physician. So it's right on, the two go hand in hand.
Welcome back to the Pulse of St. Louis. Tonight we are talking about PSA screenings and why it is important for men to get tested for prostate cancer. So, Dr. Bedwinek, we were talking about the different treatment options before we went to break. So, and I know it depends on each individual's circumstance. So, but what are the options?
There are a dazzling array of options for treating prostate cancer. It's just amazingly confusing, and I feel sorry for guys that get prostate cancer, not because they have prostate cancer, because they have all of these options in front of them and what to do. Yeah. One of the options that we are doing more and more these days is the option of active surveillance. One of the reasons that the United States Preventative Services Task Force pulled back a little bit on their recommendation is they now recognize that once a man finds out he has prostate cancer, he doesn't necessarily have to be treated. And active surveillance, we do that on everyone who has what we call low-risk prostate cancer. And actually, Mr. Bozier started off having active surveillance, and I would credit his urologist with doing exactly what should be done. He had the Gleason score is one of the most important prognostic indicators of prostate cancer. 6 is good, 7 is intermediate, 8 is bad. He started off having a 6, and it's a very reasonable thing to do to watch men who have a Gleason score 6. The PSA is repeated every 6 months. Sometimes the biopsy is repeated. We frequently use MRI these days to make a decision as to whether to do another biopsy. And that's exactly what happened with Mr. Bozier. And it was exactly the right thing to do. And so they watched his PSA, and he has a very nice graph there, but it did rise. And having his PSA rising, then his urologist got an MRI and did something else that's new today called targeted biopsies, where prostate cancer, you can't see the cancer in the prostate up until recently. And there's this very special test called a multiparametric MRI that does show the cancer. So the way that, and I realize you want me to talk about treatment, but we'll get there. The way prostate cancer has been diagnosed for the last 30 years is by the transrectal ultrasound biopsy done in the urologist's office. And it is a blind biopsy. They do the ultrasound, put an ultrasound probe in the rectum so you can see the prostate, but you can't see cancer in the prostate. So imagine that your physician said to you, you know what, you have a cancer in your breast. We're going to stick the underside of your breast 12 times and see if we can hit it and come up with a diagnosis. That's exactly what the biopsy process for prostate cancer has been over the last 30 years. Now that we get an MRI, the MRI can show an abnormality, and then the data from that MRI gets fused to the ultrasound image that's done in the operating room at the time of the biopsy, so the urologist can actually see where the cancer is and can aim at it. So that's something that we're doing these days. So that's exactly what Mr. Bozier had. His very first biopsy was the standard trust biopsy that was blind, and they got Gleason 6. As his PSA rose, he then had this MRI that showed a lesion, and the urologist biopsied the lesion, and lo and behold, it was a Gleason 7, a more aggressive cancer. And so now we're at the point, do we continue active surveillance or not? And with the PSA rising as his is rising, and now he has a Gleason 7, it is time to come up with some form of treatment.
But was it all removed, Mr. Bozier, all of the cancer? Or are you cancer-free?
I think he did a good job. I've been plotting my PSA. As I said, it went to 10.8, and then I had the CyberKnife here in SSM, and I had a PSA in October, and it went down to 1.8. I had it done 2 weeks ago, and it's down to 1.5.
Wow. So you're doing well.
I think so, yeah.
Yeah. Mrs. Bozier nods her head. He's doing well.
So the CyberKnife is a new treatment modality, and even though it's got the word knife in it, there's nothing that gets cut out. No. But what happens is it delivers an extremely high dose of radiation, and this high dose volume literally shrink wraps to the prostate itself. So it spares the rectum and the bladder neck, and some of the side effects with conventional radiation are not there. And it also doesn't have some of the side effects that the radioactive seed implant has or that surgery has. But it is new, and Mr. Bozier and I talked about this, that the data for CyberKnife is not as long as the data for surgery or radioactive seed implant or external beam. But the early data looks very promising. And he, because of the other issues involved, he elected to take that chance.
What was your recovery like?
So there was no recovery.
Really?
I walked out, there was no pain. I somehow imagined it would be like having a hot curry or something like that,
Right.
But I laid on the table with a sheet over me and watched the robot do its thing, and the only thing you could hear was the whir of the servo motors of the thing moving, And I got up, and there was nothing. No pain.
Wow.
Never had any side effects at all.
Mrs. Bozier, that had to be a big relief for you.
Oh, it was. And 5 treatments of just less than an hour each. And you've never looked back since. I mean,
it's
we were
incredible.
warned about, you know, burning on passing urine and things like that, but you didn't suffer any of
No.
the side effects.
No.
And a thing I think that I was thrilled about using the CyberKnife method was that there was no chance of the cancer escaping the capsulated, you know, part. I'm sorry, I'm not very technical here, but you weren't worried about it leaching into other parts of the body because it you know, it was non-invasive, really.
Yeah. That's good news.
From-
And Dr.
yes.
Yeah. And Dr.
Amazing.
Bedwinek, of course, you were still encouraging men to get the PSA screening.
Very definitely.
All right. Well, thank you all so much for being here. I appreciate it.
Thank you for having us.